interesting paper I read recently about the lack of thoracolumbar rotation and how it can, if you're your range is reduced on one side, your calf muscle on that ipsilateral side is having to push off more, and that can be a predisposition to getting calf strains, Achilles tendinopathy, etc. So I know we're deviating away from the spine, but
no, not at all. I mean, that's very useful stuff, isn't it?
Yeah.
Because I know we regard ourselves as holistic therapists, but actually sometimes making the connection between distal parts of the body is
I mean, because you have to really look at the whole kinetic chain. I mean, we talk the subject is a supporting spine, but we know that lower limb problems and pelvic problems are major contributors. So it's very important to assess all these things. So I would do an assessment of the lumbar spine. We're not really going into the neck on this occasion, but the thoracolumbar junction is particularly an area for compression fractures because we've got all the rib attachment area of relative instability of stiffness. And then you've got slightly smaller vertebrae. So most compression fractures are T12, L1, L2. So, if you've had anyone had a fall, particularly an elder patient, and they haven't been x-rayed or investigated, that's something to bear in mind. Okay, so the other thing I would do while you're on that position is I'm going to get you to come and sit. We're going to do a Thomas test. So the Thomas test, if you shuffle right to the end for me, Neil. Thomas test is very revealing. I do this on all patients, actually. If you lie back, bring your left knee up towards your chest. So this will give us an idea of whether some muscle groups are shortened and tightened. Most people are sitting in offices are spending a lot of the day with a hip flexed and knee bent. So what we're looking at is the position of the knee relative to the ASIS. I've seen worse. I've seen them right up here. But there's some tension there. There's also slight abduction, so there's probably iliotibial band tightness, which may be linked in with some gluteal weakness. There's also tightness in the rectus femoris because this knee doesn't sit where it should there, so that's tight. And then you compare that with the left side, and we can see this does sit lower, but there's more abduction on this side. And actually your rectus femoris on this side is not too bad. So you've got a right-sided problem. So if you're dealing with the spine, you wouldn't just do mobilizing and manipulation on the spine. You would look at the big muscle groups. You'd do a lot of stretching on iliopsoas. You would try and get the Thomas test to be symmetrical with the other side. But then you'd also, further on, you could start core exercises quite early on, but you would obviously have a program of building up strength in all the key muscle groups.